we are going to discuss today community-acquired pneumonia, simply called as CAP. Very, very common condition. Every physician, anesthetist, surgeon, irrespective of what branch they must know about community pneumonia, community-acquired pneumonia. And so as you can see here, there are varieties of pneumonias which we can see. The first one is CAP. Healthcare associated is called HCAP. Hospital acquired is called HAP. ICU acquired, and then ventilator acquired. So ventilator acquired are a little specialty. ICU acquired, hospital acquired, healthcare acquired, these are all called nosocomial pneumonias. Nosocomial means related to some health institution and some provider. Sometimes this healthcare associated is also branched as the people who are in the asylums, ashrams, old age homes. They also do have institutional pneumonias because certain things are common there. Now, what is the definition of pneumonia? One thing, it is an acute process and it involves the pulmonary parenchyma and associated with acute infection symptoms, presence of an infiltrate on the chest radiograph, auscultatory findings consistent with a consolidation or pneumonia, in a patient who is not hospitalized or not residing in a long-term care facility for more than 14 days before the onset of symptoms. This is to exclude all nosocomial pneumonia. So, four important aspects. It's an acute in onset, parenchymal involvement, lung infiltrate, chest radiograph positivity, auscultatory findings, and not hospitalized or in a care facility for over 2 weeks before the onset of symptoms. All are important. Now, we are following mostly the guidelines of the American Thoracic Society, Infectious Diseases Society of America, ATS and IDSA joint effort. So we're going to follow these international guidelines as far as pneumonia is concerned. Why? Because whatever we speak should have relevance in the international context. Then only we will be able to understand what we are talking is the same language as what other country people are talking. Not only that, when you follow standard guidelines, you have a protection from the legalities. Otherwise, if you treat on your own without following the guidelines, you are bound to be questioned on what basis did you do this. Then you have to have some textbook evidence or something, but better to have always the guidelines. Why guidelines? Not only for legal protection, we want to practice EBM, evidence-based medicine, best outcomes we want to give to the patient, best use of the resources we want to have, and restrict the idiosyncratic behavior of the physician. Physician on his own, he may be treating on her own. So that we have to avoid it. Legal protection and for research needs and to educate. If we treat according to guidelines, we can tomorrow use the cases to educate the students. Gain public confidence when you use the guidelines. Now, most importantly, there are two types of presentations. One is called the classical pneumonia, the other is called the atypical pneumonia. So what is classical pneumonia? What is classical pneumonia? Classical pneumonia is sudden onset of CAP, high fever, shaking chills, pleuritic chest pain, shortness of breath, productive cough, rusty sputum, blood-tinged sputum, poor GC, high mortality up to 20% in patients with bacteremia. Usually Streptococcus pneumoniae is the cause. Again, I am repeating, classical versus atypical presentation. Classical pneumonia, sudden onset, high fever, high when I say more than 103, 102 degrees, shaking chills, pleuritic chest pain, shortness of breath, cough, productive sputum, rusty sputum, Rusty sputum means, brown colored sputum. Rust, what rust is. And then maybe blood tinted sputum. Poor general condition. High mortality up to 20% in patients with bacteremia, and S pneumonia is the common causative agent. The other variety is the atypical pneumonia. Atypical pneumonia is gradual in onset, insidious, low-grade fever, dry cough, not productive, no blood tint, good GC. This is called walking cap. Walking cap means atypical pneumonia. Low mortality, 1 to 2%, except in case of legionellosis. Legionellosis is having poor prognosis. What are the causative agents here? Mycoplasma pneumoniae, chlamydia, Legionella, Rickettsia, viruses are the causative. So the etiology differs between classical and the atypical. Atypical, gradual onset, insidious, low-grade fever, dry cough, no sputum, no blood tinting, good general condition, walking cap, 1 to 2% mortality, Mycoplasma, Chlamydia, Legionella, Rickettsia viruses are the causative. First of all, the moment you see a patient, you should be able to decipher, am I dealing with a case of classical pneumonia or an atypical pneumonia? Because the treatment differs. See, if you see on the atypical side, the drugs that you use are very different from that you use for S pneumonia. So by the onset itself. Now, what are the causes of blood tinted sputum or hemoptysis? Common causes. Tuberculosis. Come. Louder. Bronchiectasis. Bronchitis. No. Bronchiectasis, yes, possible. Lung abscess. Okay. Malignancy. Okay. Tropical pulmonary eosinophilia. Okay. Loeffler syndrome. Good pasture syndrome. Any bleeding diathesis. Pneumonia. So when the patient has got blood in the sputum, you must be thinking of the following conditions. And of course, the non-cardiac condition, mitral stenosis. Because mitral stenosis with pulmonary edema produces hemoptysis. In our country, the commonest cause of blood in the sputum is tuberculosis, mitral stenosis, carcinoma, then pneumonia, tropical eosinophilia, good pasture syndrome, Loeffler's, bleeding diathesis. Either iatrogenic or natural. That means you would have given anticoagulant to the patient may cough. So always remember those. This is a differential diagnosis of hemoptysis. All of you must be aware of it. Now, what are the routes of transmission of CAP? What are the routes it can get in, the organism can get in? It can go inhalation, or it can be aspirated by the child and hematogenous through the blood, through the septicemia, bacteremia, getting into the lung and producing pneumonia. So inhalation, aspiration, hematogenous. So in the history, always it is important for you to look for any possibility of aspiration. What are the possibilities of aspiration? Unconscious patient, child, inebriated and drunken patient, people who had epileptic fits, people who have drowned themselves in the pool of water. Isn't it? When you think of aspiration, did you swim and then get yourself drowned during the last few days? And the second thing is, do you have epilepsy? And do you see the patient in unconscious state or inebriated state or anything? So and then a child also can have very young infants. They can have regurgitation and aspiration. Okay. Corrosive poisoning also can lead to aspiration. That can lead to secondary pneumonia. So these are all the things you keep in mind. In my MBBS final year, I had a case of pneumonia. It is very clear-cut case of acute pneumonia it was not called CAP in those days, we called lobar pneumonia. So I diagnosed the lobar pneumonia. And the same case was given, it's a prize exam, not university exam. It's a competitive examination for prize in medicine. So the short case was pneumonia. I got the short case and I got it right. And I got the prize and others did not get the prize. Why? The history was the mother was telling the child is an epileptic and the epilepsy has produced aspiration. That I told, the others could not get it. That was the reason. That's why, as a person who is experienced and telling, even in those days, taking history was so important for me. The moment the examiner asked me, I said, it is lobar pneumonia, right lower lobe due to aspiration. He did not ask me one question, go. Later on, the announcement was very easy. By then, all the other 4 candidates are examined. None of them uttered aspiration. He didn't question me at all. Because that was the differentiator. Because all findings are there in the case sheet and he understood that I examined and the theory is there. Okay. Now, what are the predisposing factors or risk factors for pneumonia? Very important predictor is, yes, the person is elderly, he is more prone for pneumonia. Second one is obesity. People who exercise, they are protected from pneumonia. People who are sedentary, obesity, why? Why obesity predisposes to pneumonia? Any idea? The lower part of the lung is normally not ventilated. Only 1/3 to 1/4 to the half of the lung is ventilated and the lower zone of the lung is always sleeping. Because this fellow never tries to take full deep breath or exercise. And particularly the obesity, the diaphragm is pushed up and lower lung zones are collapsed or compressed. And the chances of infection are there when something is not being used. A person who is regularly exercising, sitting upright like this and working and taking deep breath always, the lower lobes are ventilated, the chances of pneumonia. Smoking, peripheral vascular disease, asthma, COPD are important forerunners of pneumonia. If a child has asthma, chances of pneumonia. If an adult has COPD, the chances of pneumonia. The other day, only just 3 days back, a student, PG student from Taxila American University presented a case of pneumonia. The catch in that particular case is the patient is a cook. They were living in somewhere deeper part of the Madhya. There they use this open fire, the open fire cooking. And then she was there as a cook for 30 years. She works as an Anganwadi worker in one of the things, and she cooks food every day with that open fire. So what will happen to her? She has developed COPD because of the smoke pollution that COPD has produced. This pneumonia, the candidate could not pick it up. He lost his examination. When I asked him clearly, can you connect the profession with the pneumonia? He could not. He was saying, what is her profession? She is a cook in Anganwadi. Then how do you relate that? He is not able to. No, you see. How important is that? COPD and asthma, immunosuppressive diseases, HIV are important predisposing factors or risk factors. Institutionalization, of course, old age homes, etc., and dementic patients who don't have proper mentation, they cannot take care of the respiratory tree properly, then obviously they will have a risk factor for pneumonia. Okay, these are the important factors. Of these, I remember age, obesity, smoking, asthma, COPD, HIV, immunosuppression. You will never forget. Always important. So whenever a patient comes, do these checkups also. Now, what is the epidemiology of pneumonia? Why am I interested in the epidemiology? If I know the burden of illness and how it is spread, I can expect what sort of population will be target population for the pneumonia. 4 to 5 million cases annually, around 5,000, 500,000 hospitalizations. Not all pneumonias require admission. 20% only require admission. Pneumonia is a fatal disease, 45,000 deaths, both in the very young, both in the elder. Extremes of age, the mortality is very few cases in 18 to 24 years. Probably highest incidence, less than 5 and more than 65. Mortality disproportionately high in 65 years. Overall mortality is 2 to 30%, depending on the age of the patient. Hospitalized patients, the mortality is it is less than 1% for those who are not requiring pneumonia, hospitalized. Suppose you are able to treat the patient at home. I will classify now into 3 groups. A, who require domiciliary treatment only. B, those who require short-term hospitalization in a medical ward. And C, who require in ICU admission. So the mortality is very low in the domiciliary or non-hospitalized patients. For obvious reasons, because milder cases only we don't admit. Now, the pathogens involved, 40 to 60% no causative agent can be identified. 2 to 5% of the cases, 2 or more agents may be identified. Generally, unless it is an institutionalized pneumonia, like hospital acquired and then ICU acquired, ventilator acquired pneumonia, we do not have to do culture. The guidelines say cultures are only of academic end. You don't have to do in a community acquired pneumonia. You have to use empiric antibiotic. That is the guideline today. Empiric antibiotic means we don't require to know the spectrum. Depending on this one of broad spectrum coverage, they will give. Now you see. So 56% are S pneumonia. This is called pneumococcal pneumonia in olden days. Today we call it as streptococcal pneumonia. S pneumonia. H influenza is the next one. Chlamydia is the next one. Legionellosis, S. aureus, Mycoplasma, gram-negative bacilli, and finally virus 9%. So that is the distribution. So basically, around 56% are S. pneumonia, 10% are influenza, 6 chlamydia, 6 legionella, 5% mycoplasma, 4% gram-neck bacilli, and then others are viruses, 9%. Streptococcus pneumonia, also called the pneumococcal pneumonia, most common cause of CAP. About 2/3 of the CAP are due to S. pneumonia. These are gram-positive diplococci, and typical symptoms are malaise, shaking chills, fever, rusty sputum, pleuritic chest pain, and cough. What is the cause of chest pain and pneumonia? Pleural involvement. It is if they develop effusion, the pleural rub disappears, chest pain. Till they develop the effusion, the rub will be there, and that will be pleuritic chest pain. How do you differentiate pleural rub from pericardial rub? Basic difference is anything related to respiration or pleura it is arrested once you hold the breath. Ask the patient to hold the breath. No pain, no rub. But cardiac rub, pleural, the pericardial rub will continue to be there because you can't hold the heart. Try and hold the heart. Can you? You can't hold the heart. So pericardial rub continues. Second thing is, if you press the stethoscope firmly on the chest, the pleural rub is intensified because it is superficial. Pericardial rub doesn't. Pericardial rub has a frequency of the heart rate. Pleural rub has a frequency of the respiratory rate. Pleural rub is associated with chest pain. Pericardial rub may not be associated. Okay. So these are some of the basic clinical differences. So 25% will have bacteremia and have serious side effects, and especially in those immunocompromised hosts. So what are the special features pathogen-wise? Depending on the pathogen, how the pneumonia affects the lung. Okay, typical pneumonia is S. pneumoniae, H. influenza, Mycoplasma catarrhalis. Blood tinged sputum, pneumococcal, Klebsiella, and then Legionella. Okay, somebody has got blood tinted sputum. We are looking for Klebsiella and then the pneumococcal pneumonia and Legionella. H. influenza, CAP is associated with pleural effusion. If you have pleural effusion and pneumonia, most likely cause is H. influenza. S. pneumonia, commonest penicillin resistance problem is there with S. pneumonia. S. aureus, K. pneumonia, P. aeruginosa, Pseudomonas aeruginosa, not in a typical host. Usually they won't come in a normal host. In an immunocompromised, very elderly, institutionalized, you get those people. S. aureus causes CAP in post-viral influenza and serious CAP. K. pneumonia primarily in patients with alcoholism. A known alcoholic comes with pneumonia, it is probably K. pneumonia. And then P. aeruginosa causes CAP in patients with CSLD and in nosocomial infection and congestive cardiac failure. Okay? People with liver disease, P. aeruginosa. Alcoholism, K. pneumonia. Pleural effusion, H. influenza. Like that, depending on the profile of the patient, the type of pneumonia, etiology-wise, will differ. Aspiration CAP is by multiple pathogens. Because once you have an aspiration, it's not one organ. Extrapulmonary manifestations, you get it only in atypical pneumonia. In typical pneumonia, there are no extrapulmonary manifestations. Okay, these are such a very important conditions that you know. Now, S. aureus CAP is dangerous. The CAP is not common due to S. aureus. It is multilobar involvement, post-influenza complication, class 4 or class 5. Pneumonia is classified into 5 classes. This will be into class 4 or 5 in a compromised host with comorbidities, elderly, and methicillin-resistant Staphylococcus aureus. A problem occurs, empyema and necrosis of lung with cavitation. Multiple pyemic abscesses, septic arthritis, hypoxemia, hypoventilation, hypotension are common. Vancomycin, linezolid are the drugs of choice. This is about Staphylococcus aureus, staph pneumonia. Staph pneumonia is not common but dangerous. This is, MRSA will be there. There will be hypoxemia, hypoventilation, hypotension. Vancomycin and linezolid are the drugs of choice. They have extrapulmonary manifestations like multiple pyemic abscesses and septic arthritis. What are the chronic suppurative lung diseases? Suppurative lung disease, CSLD. Lung abscess, bronchiectasis, empyema, lung abscess in a cavitatory tuberculosis. The patient had a cavitatory tuberculosis, open cavity communicating with the bronchus. He had a secondary abscess. Tuberculosis can also have a suppurative lung disease. What is the classical feature of suppurative lung disease? Copious sputum, maybe purulent sputum, foul-smelling sputum, may have blood. Large quantity of sputum, foul-smelling sputum, and then purulent sputum, and then maybe blood. 4 or 5 causes. Bronchiectasis, lung abscess, secondary lung abscess, tuberculosis, and then empyema. Then, age-wise, what is the type of CAP? We have seen pathogen-wise, we have seen the severity-wise. Now we are seeing age-wise distribution. Less than 5 years, around 800, 900 cases. And then 15 to 17, still little higher. 18 to 24, least affected. And then 45 to 64, more than 65, number of cases that occur age-wise. So this is also important, age distribution. Now, okay, this is the incidence. What is the mortality? Age-wise mortality. 0 in younger children, you see, everybody is 0, 0, 0. And then slowly the mortality starts. And above 65, you see, the mortality. 80%. Okay? 74.9. Untreated pneumonia in an elderly can cause a death to an extent of 80%. Whereas in the younger, so that is why age is such an important factor. You have a scoring called the curb 65. You know curb 65? You use it in your word. Anesthetists may be using curb 65. I will tell you about that. Okay. Risk factors for hospitalization. Who are the ones who need to get admitted? Older patients, unemployed, unmarried, recurrent common cold, asthma, COPD, steroid or bronchodilator use, chronic diseases, diabetes, congestive heart failure, associated neoplasia, amount of smoking is more. Alcohol is not related to increased risk for hospital. Alcoholics can have Klebsiella pneumonia, but there is no increased risk for hospitalization. Now, risk factors for mortality. Which is my patient? They will ask, the moment his patient is admitted or brought with pneumonia. When you say pneumonia, there is bad fluid in the lung, in the parenchyma, and then they are worried. They say, is it okay? Will he become all right? Like that they will ask. Then the answer depends on this. What is the age of the patient? 65. Is there evidence of bacteremia, as in case of pneumonia, staph pneumonia, Staph aureus pneumonia, MRSA pneumonia, Pseudomonas pneumonia, extent of the radiographic changes, degree of immunosuppression, amount of alcohol consumption. These are all the predictors of high mortality. Now you see, as per the bacteriology in the hospitalized patients, again, strep pneumonia outstands amongst all, and C. pneumoniae, viral, mycoplasma, Legionella, H. influenza, gram-neck bacteria, enterobacteria, psittacosis, Coxiella burnetii, Staph aureus, M. catarrhalis, and others. So it's very important to know the etiology also. Now, how do I evaluate the patient? All this is etiology, bacteriology, pathogenesis, risk factors, mortality, risk factors for mortality, all that we learn. Now, how do I evaluate the patient? History, very important. What are the points in the history? Sudden onset, high fever, shortness of breath, cough, sputum, rusty sputum, chest pain, chills and dryness. Patient may be very weak and, red, almost, not comfortable at all. This is the presentation. Then physical examination. Physical examination will reveal what? Reveal findings of consolidation in the affected area. Now the question is, what are your findings of consolidation on exam? That you have to tell me. When you examine just inspection, palpation, ask. Normal patient will not have to have it. First you observe when you inspect. Oh, he is breathless. Tachypnea may be there. There may be associated decreased movement in the area involved because of pain. There may be reduced movement of the chest wall. Anything else in the inspection? Okay. You have put your hand. You started palpating. What did you notice? Movements of the chest wall will be decreased when you examine on that side. And when you put this and ask him to say 1, 2, 3, what will happen? Vocal fermetus is increased. That you will confirm by vocal resonance. VF increased. And there may be a palpable rub. When you put your hand, the pleural rub may be palpable under your hand. And percussion, what sort of note you get? Dull note. What are the notes that we have in the lung? Normally resonant, hyper-resonant, impaired, dull, stony dull. Now you should know What are the conditions which produce hyperresonant node, and then impaired node, dull node, stony dull node? You have to know. Stony dull node, pleural effusion and mass. Dull node, consolidation, cavity. Impaired node, maybe early consolidation, may have an impaired node. Hyperresonant, emphysema. Okay. Nowadays, none of you are doing those things. Simply go for CT, MRI of the chest to diagnose. No clinical examination. So your stethoscope is hung to the wall. You don't need to examine and directly ask for an investigation. That's not correct. Okay. Now, what are the auscultatory findings?
Type of breath sound.
Breath sounds. What type of breath sounds? Bronchial breath sounds. Bronchial breath sounds are of three types: tubular, cavernous, and amp. What do you get here? Tubular. Not cavernous, because we don't expect a cavity in the early pneumonia unless you leave him without treatment. And amphoric also, we don't expect that. Tuberculosis findings. So tubular breath sounds will be there. Bronchial breathing will be there, associated with adventitious sounds. What adventitious sounds do you expect? Crepitations. What sort of crepitations? Coarse or fine? Coarse, leathery, creaky crepitations. What condition? Bronchiectasis. Coarse, leathery, creaky crepitation. Coarse crepitations. Post-tussive crepitation. Always you ask the patient to turn that side and then you ask. Because before coughing, yes, few creps may be there even in an arm. Okay. So these are some of the classical findings of pneumonia. History, physical examination, chest X-ray. That is the first level. Then what you know? There is no infiltrate. Or there is an infiltrate or a clinical evidence of CA. So there may be infiltrate, or sometimes the infiltration can take time to produce an X-ray shadow. If he comes very early in the first few hours, there may not be an infiltrate, but clinical signs will be there. So, no infiltrate, alternate diagnosis. You have history, physical examination suggestive of pneumonia. You take an X-ray, no infiltrate, consider it is heart failure or some other alternate diagnosis for the breathlessness and cough. If there is an infiltrate with clinical evidence of CAP, evaluate whether he needs admission or outpatient treatment. Because that is crucial, no? Everybody we cannot admit. All pneumonias, there are no beds here in this country to admit every pneumonia patient. They cannot afford also. So if there is a need, only we admit. Even for COVID, what we were telling, COVID pneumonia also only in case of necessity only get admitted, otherwise home management. Here also same. Need for evaluation for admission. And how do I decide? You do two types of scoring. One is called the port, the other is called the curb 65. What is curb 65? What is port? I will show you in the coming slide. Okay. It decides into three categories: outpatient, medical ward, IC. Okay. So evaluate the need for admission and look for the curbs, this one, and then CAP management guidelines, rational use of microbiology laboratory, pathogen-directed antimicrobial therapy whenever possible, prompt initiation of antimicrobial therapy, not waiting for the bacteriology, decision to hospitalize based on the prognostic criteria called port or curb 65. So you have to use the microbiology rationally. Not that every pneumonia patient requires a culture. We don't require. Community-acquired pneumonia, generally culture is not required. And if you require a pathogen-directed one in an institution, in an ICU, in a ventilator setup, that is a difference. And don't wait for the bacteriology man. No, sir, I sent for culture. I am waiting when the culture report will come after 72 hours. Patient you lose. Immediate antibiotic, empiric antibiotic treatment is the rule. And studies have proved that those patients which are put on immediate antibiotic treatment have fared very well compared to those who waited for 48 or 32 hours for the culture report to come. And your empirical choice should be broader so that it will cover, what are all the, organisms you have. And once you get the culture, you narrow it down to that. Okay. So today's watchword is empiric use of antibiotics, not waiting for the culture. Culture doing is only optional. It is not mandatory. Okay. Now we have more than culture. You have to do port and carbucity. Now what immediately the moment patient comes with pneumonia symptoms, you write chest X-ray, sputum culture, but never write port curve. That is to be assessed. Sputum culture is in the end. First clinical examination, symptomatology, then X-ray, then port, then curve, then probably curve. That should be the order. Now, port scoring. This is also called PSI. Okay. Pneumonia Patient Outcomes Research Team. Port. Port means Pneumonia Patients Outcomes Research Team. There was one sort of research organization. They conducted this, and that is why this is called the. What is PSI? Pneumonia Severity Index. PSI means Pneumonia Severity Index. Now, how do I score? Age in years for men, age in years 50 years, 50 points. Age in years 50 for women, age minus 10. Let us say a man is there, 50 years, 50 points. Same person, woman has come, reduce 10 points, 40 points. Nursing home resident in sort of orphanage or in an old age home or some second destitute care home, 10 points you add. Comorbid conditions. Known patient of neoplasia, 30 points. Known patient of liver disease, 20 points. Congestive heart failure patient, 10 points. Cerebrovascular disease, 10 points. Renal disease, 10. Very simple. You don't require any blood test. Nothing is required for PSA scoring, just your clinical observation only. Then comes the other parameters that you add. Clinical parameters you have to add. Okay. Now, first thing is what is the age of the patient, whether he has got comorbidity. Age of the patient, as it is you take. Age of the patient as it is you take. But if the woman means 10 points less. Comorbidities like neoplasia, liver disease, congestive heart failure, cerebrovascular disease, kidney disease are given depending on the weightage 30, 20, 10, 10, 10 points. Now I have to use the clinical parameters, then the investigatory. Fine. Clinical parameters, patient has altered sensorium, 20 points. Respiratory rate more than 30, tachypnea is there, 20 points. And then systolic blood pressure less than 90, 20 points. Temperature less than 35 or more than 40 degrees centigrade, 15 points. Pulse rate more than 125, 10 points. Now patient is altered sensorium, tachypnea, hypotension, hyperpyrexia, and then tachycardia. These have got, and the temperature is low also, you have to record that. Investigatory finding. What is the arterial pH like? If it is acidemic, less than 7.35, 30 points. One more than 30, 20 points. Serum sodium, less than 130, 20 points. Hematocrit, less than 30, 10 points. Blood glucose, more than 250, 10 points. PaO2, 10 points. X-ray evidence of pleural effusion, 10 points. PaO2 reduction, PaO2, decreased PaO2, 10. So this is how I have to use an extensive scoring based on the age and then the nursing home resident or not, comorbidities like neoplasia, liver disease, heart failure, cerebrovascular disease, and kidney disease. Clinical findings, altered sensorium, tachypnea, fall of blood pressure, hyperpyrexia, tachycardia have to be given due weight. Investigations, acidemia, BUN, low sodium, low hematocrit, high sugar, low PaO2, and X-ray evidence, pleural effusion. After all the things, what will happen is you will get a score. Some number will come. Now I have to classify these fellows into you see now, depending on the score, predictors are absent, less than 70 score, class 2, 71 to 90, class 3, 91 to 130, class 4, and more than 130, class 4. Okay. Now, the treatment depends upon into which category the patient falls. Class 1, class 2, outpatient treatment. Class 3, admission into medical ward. Class 4, class 5 may require ICU. Class 4, class 5 must be ICU treatment. So this is very important for us to know the port, but it requires some evaluations. You require to do some tests like all these things. Now, you see here. So after knowing to which class the patient belongs, PSI score, the mortality rate is the guideline for you to admit or not. Class 1 patient, the mortality is less than 0.4%. So he can be comfortably managed at home. Class 2 patient, that means PSI score less than 70. PSI score, no risk factors, outpatient. Less than 70 score, that is again the mortality is still lower, treat him as outpatient. Class 3, between 71 and 90 PSI score, 0.9 to 2.8 is the mortality, you have to admit. Class 4, 91 to 130, you have to keep him for a longer while. Class 5, more than 130, the mortality is as high as 30%, inpatient in the ICU. So you are not following these things. From tomorrow onwards, whenever you get a case of pneumonia, you do the port score, stratify them into class 1 to class 5. Depending on that, you decide what to do. You are very happy and patient is also very happy by doing that. Supposing I want to quickly do, this is called the curb 65. Curb means 65 stands for the age. Is he having more than 65 or less than 65? C for confusion, B for BUN, R for respiratory rate, another B for systolic blood pressure, diastolic blood pressure. B has got systolic blood pressure, diastolic blood pressure, R respiratory rate, U BUN, urea, and then C is the confusion, altered sensorium, and age is 65. Now what you have to do? Every patient of pneumonia, you have to do the curb and you have to do the port. Depending on the curb, the guidelines. Curb score 0 to 1. None of these points are present. A patient is less than 65, systolic blood pressure normal, diastolic blood pressure normal, respiratory rate is not 20, and BUN is less than 30. There is no confusion. The score is 0. Or at best, he may have 1. 0 to 1. Home treatment. Then curb 2, at least 2 of those points he has got short hospitalization. Curb 3, he has got hospitalization, medical ward. Curb 4 or 5, that means all the factors are present. Confusion is there, BUN is there, respiratory rate is high, blood pressure is low, age is more than 65. In that case, he will have 4 or 5 and he needs ICU care. So how very clear-cut these guidelines are. These are not my own brain's compositions. These are what the international guidelines are telling. You people are trained physicians in a good quality care hospital qualifying for a DNB. You must know how to classify your patients. Stratify them as per the prognosis. This is prognosis-based stratification. 0 to 1, very good prognosis, home treatment. 2, moderately good prognosis, short hospitalization. 3, patient has to get medical ward. 4 and 5, very high mortality patients. They must be admitted for the ICU care. So we learned port and we learned also curve, how to use our two parameters. Now, this is called the algorithmic approach for patient management of CAP. So there is a CAP patient has come. How do I know CAP patient? He has got symptoms. He has got clinical evidence. When I examine, he has got an infiltrate. That means he is a patient of CAP. Now the first question is he less than 50 years or more than 50 years? Now, less than 50 years, are there comorbidities or no comorbidity? If a patient doesn't have neoplasia, heart disease, lung, liver disease, cerebrovascular accident, is not obese, non-alcoholic, and not institutionalized fellow, less than 50 years, no comorbidity, no curb is required, because curb will be zero. Because our comorbidity is zero, that means curb is zero. That means he is class 1 patient. He can go only in the OP. Okay. There are comorbidities present, that is curb at least 1 or 2 points are there, then we have to decide. Comorbidities present, comorbidities are present, comorbidities are absent. More than 50, you have to do PO. Okay. Depending on the port scoring, you have step 1 is the age, step 2 is the comorbidity, step 3 is the curb and port scoring, step 4 is your admission, and then OP treatment. So this is the stepwise approach or algorithmic approach for this particular patient. So if the port class 2, class 3, class 4, class 5, he requires IP admission or ICU admission depending on the stage in which he is. Okay, now, who should be hospitalized? Class 1 and class 2 usually do not require hospital. Class 3, brief hospitalization. 4 and 5 usually require hospitalization. Severity of CAP with poor prognosis. When do you have to counsel the patient, attendants and patient for poor prognosis? Supposing a patient has got the following thing, you should take him to a room, the attendants, look here, your father, 80-year-old man got admitted, he is having these following risk factors. We don't know whether he will respond or not. Don't tomorrow think that we have not done and informed you. You could tell them. Communication is as important as diagnosis. You may diagnose and manage, but if you don't communicate, if you lose the patient or some complication develops, they will throw stones, they will hit, they will bite, they will do whatever they want. These days, in our days, patient cannot touch a doctor. Patient is there, doctor is there. There's no question of patient attacking the doctor. Nowadays, it's not like that. They are a consumer, you are the provider, so consumer problems are there. You have to be very careful. So, respiratory rate more than 30, PaO2 by FiO2 less than 250, and then PO2 less than 60 on room air. This is a severe CAP. Need for mechanical ventilation, multilobar involvement, hypotension, need for vasopressor, oliguria and altered mental status. If a patient has got altered mental status, oliguria, hypotension, needing vasopressor to keep the blood pressure, multilobar involvement, a patient has got patchy multilobar involvement, and he is needing mechanical ventilation. Room air saturation is less than 60, or PaO2 by FiO2 is less than 250, probably some ARD is setting in, and then respiratory rate is more than 30. This is a patient with a poor prognosis. Now, criteria for ICU admission. Who must get into the ICU? Major criteria, minor criteria. At least 3 of the minor criteria. Everything is documented. If you go according to this presentation, there won't be any problem for you or for the patient. Okay? Invasive mechanical ventilation required, septic shock with need for vasopressor. These are the 2 direct indications for ICU. He has septic shock and he is in need of vasopressors to support the blood pressure. Or he is SpO2 is so low, or the PaO2 by, as I showed you in the previous slide, PaO2 by FiO2 is less than 250, then he is a case for mechanical ventilation. Minor criteria: patient is confused, blood urea nitrogen is more than 20, respiratory rate is 30 or more, core temperature less than 36, severe hypotension, PaO2 by FiO2 ratio less than 250, multilobar infiltrates, WBC less than 400, instead of leukocytosis, you are seeing leukopenia. Instead of good thrombosis, there is thrombocytopenia. This is a minor criteria for admission. So, two direct criteria and any three of the minor criteria. If he has direct criteria, no problem. You have to admit him. If he has minor criteria only, doesn't require mechanical ventilation, no septic shock, but he has got any three of the 6 here, he is qualifies for ICU admission because of confusion, disorientation, urea is more, respiratory tachypnea is there, hypothermia is there, hypotension is there, the PaO2 FiO2 ratio is less than 250, multilobar infiltrates, poor WBC response, and then platelets are such a case, you may require ICU. Now, what are the tests that you need to ask? Admitted all right, then immediately some investigation. Already you would have taken an X-ray test, preferably take a lateral view also. To know which segment of the lung is affected, a lateral view will be used. PA and lateral view, CBC with differential count, BUN and creatinine, sugar values, liver, the basic minimum. And of course, serum electrolytes, because hyponatremia itself is a known risk factor, and oxygen saturation. I have put 3 in the gray color because the guidelines are silent whether you should do a gram stain or culture of the sputum or pre-treatment blood cultures. These are not indicated. Pre-treatment blood culture, culture of the sputum, gram stain, you may do it in an institution like this, but in general, it is not required. That is why there is the gray color. Earlier days, the teaching around 20 years back, you do gram stain, you do culture, you do blood culture, all that. That is not required now. Empiric antibiotic treatment and doing the basic, doing port and doing the curve are essential. Okay. Value of a chest radiogram. Is it indicated or not? Yes. Usually needed to establish the diagnosis. My diagnosis is based on symptoms, clinical examination, X-ray. These are the basic. It is a prognostic indicator. The multiple lobe involvement, poor prognosis. Pleural effusion, poor prognosis. Okay. COPD underlying with pneumonia, poor prognosis. Malignancy underlying pneumonia, poor prognosis. So X-ray gives me a prognostic indicator. And it also rules out other disorders. Okay, somebody has got a cardiomegaly, left ventricular enlargement, right atrial overload, pulmonary edema, and then crypts in the lungs. And it is not pneumonia, it is heart failure or other diagnosis. May help in the etiological diagnosis. As I told you, I will show you some good X-rays from my own collection of my practice. Those X-rays are, they speak volumes. To know from the X-ray itself, you can say this could be the etiology. Now, what are the X-ray patterns which will help me to diagnose the pathogen? Without even doing culture, I can surmise that this could be the pathogen when I see these X-ray patterns. There is a lobar involvement. Lobar means upper lobe, lower lobe, middle lobe. On the right side, any one particular lobe is consolidated. Okay. Yes, pneumonia, Klebsiella, H. influenza, gram. These 4 produce lobar consolidation. There is a patchy pneumonia, like here and there, like cotton applied on the lung. Atypical pneumonia, viral pneumonia, legionellosis, or patchy pneumonia. Interstitial pneumonia, viral pneumocystitis, carinite, and legionella. Cavitatory tuberculosis, cavitatory lesions, anaerobic, Klebsiella, previous TB, Aeruginosa, fungi. Large effusion, Klebsiella, anaerobes, and staph. Very easy, you see now. You see a lobar pattern, your pneumonia, Klebsiella, H. influenza, gram negative, you cover. Patchy, mostly atypical pneumonia, viral liaison. Interstitial, viral PCP liaison. Cavity is there, anaerobes, Klebsiella, tuberculosis, SRS, and then fungi. Large effusion, staph, anaerobes, and Klebsiella. Okay, effusion is common in Klebsiella with alcoholism. Okay, now, gram stain of sputum. The sensitivity of gram stain is 57% for S. pneumonia and the specificity is 97%. For H. influenza, 82%, 99%. Now the question is what is sensitivity and what is specificity? I don't have an idea. Anyway, one day I will tell. Simply I will tell now for your purpose. The ability of the test to rule out disease is called sensitivity. The ability of the test to confirm disease is called specificity. Supposing I see Mycobacterium on the slide, it is specific or sensitive? Very specific. It rules in the disease. Suppose I don't see the Mycobacteria on the slide. Can I say patient did not have tuberculosis? The sensitivity is very poor. The specificity is very high. Okay. Now, I take an X-ray chest. It is normal. That means I can exclude the disease. Sensitivity is very high. But specificity is very poor. Shadow may be today's, yesterday's, long, old shadow, tubercular, some other disease. I don't know if pneumonia. So it is not specific for a disease, but it in general rules out the disease. It's a very sensitive test. That is why in tuberculosis we use a sensitive X-ray and a specific sputum to combine the goodness of the sensitivity and the goodness of specificity to make a diagnosis. Okay, a sensitive test always separates the healthy people from the diseased ones. The ones who are negative on the test you can surely say, okay, these are not. A specific test always separates the diseased people from the other. But in the other group, there may be some with the disease, but we separate them, those with the disease, outside. That is a specific test. Some other day I will show you how to calculate that. Okay. Good sputum sample is obtained only from 39% of the patients. They will give what? They will give saliva or from the tongue. What will be there on the tongue or the saliva? Nothing. So, what do they have to do? Good. How to collect a good sample of sputum is itself a technique. Patient should go to the corner of a well-aerated room, if preferably an outdoor place in a veranda, and then sit there, not stand, and then bend forward, have the cup of the sputum there, and then breathe 3 or 4 times deeply, then cough vigorously, and then bring out the sputum, and then collect the sputum in the chest. This is the method. Not like that, standing on the bus stop. So many people, they don't know how to collect. Doctors don't tell because you don't know. If you know, only you will tell. If you don't know, what do you tell? This is what collect sputum. He may not even understand sputum. He may bring urine. You have to tell in his language. His language he may be from Kerala. What do you call sputum in Malayalam? Kapam. Okay. In Tamil? Tamil you don't know. Tamil it's called chali. Chali. C-H-A-L-I. Telugu also kapam. Kapam. Not this one. From the saliva. So why I am telling? That is essential for us. The story is total, we have around 70 slides. We have come to how many slides we have come? 33 slides. I think it has to continue after some time. Then we will probably stop at some logical point. Pathogens retrieved from blood culture. Supposing you do blood culture, what are the pathogens that can come? Okay. Yes, pneumonia is the commonest. Enterobacteriaceae is the next common, and then Staph aureus is the third one, and finally the others are. So, from the blood culture, this is not sputum culture. Sputum culture, I have already shown this ring diagram. Now, the blood cultures will yield S. pneumonia 70%. Remaining are all 30%. 16 Enterobacteriaceae and Staph aureus. And so, these are the pathogens we retrieve. Mortality of calf based on the pathogen. Which pathogen is more likely to kill the fellow? As P. aeruginosa, mortality is high. Klebsiella pneumonia, higher. S. aureus, 31. Legionella, 14. S. pneumonia, comparatively lower. This is the commonest. And C. pneumonia, 9.8%. H. influenza, 7. To tell me what means, patients who have grown these three are at a greater risk, particularly S. aureus and then K. pneumonia and P. aeruginosa. The first three have having a greater risk of this one. Okay, we'll stop here and then treatment part we will take up. So we have done everything, whatever is required, examined, understood the pathogenesis, pathology, microbiology, etiology, risk factors, stratification, curve score, port score, and then prognostication, and then whether to admit or not to admit, all those things we have understood. Now we have to treat the fellow. How to treat the patient, we will see in the next class.